So welcome everybody. It's my great pleasure to welcome you to a chat that I'm going to have with my good friend Gary Landsberg. Gary and I were trying to work out when we sort of first got to know each other, and we came to the conclusion it was probably on a paddle steamer in Salt Lake City in the year 2000. How does that sound?
Close
Gary,
enough.
yeah,
We were
Gary,
both on the same steamer in Salt Lake, so it
yeah.
was then or before.
I'm sure it was round about then. And Gary is one of those people who has the most incredible energy. And if ever you want something done, or somebody lets you down and you need somebody to bail you out, Gary is the person who does it. He is so good. I don't know. I mean, people often say I'm an insomniac, but I don't know where he finds the hours in the day to do everything that he does. Gary is currently the VC of CanCog Incorporated, where he coordinates the canine and feline trials and develops the models for clinical trials. And we'll talk a little bit about that work, no doubt, with both cats and dogs. And they have been at the forefront, particularly on sort of developing treatments for fears, cognitive dysfunction, and various other things, travel as well. I know you've developed models for that as well. He's also Fear-Free Head of Research and Practice Certification. He's a VIN behavior consultant, although I think have you just finished doing that, but you've been doing it for donkey's years.
Yeah, I let up on that a little bit, so I just monitor, I lurk.
And he's a dual diplomat. He has both the American certification and the European one. And I'm sure Gary won't mind me telling you this. And that is despite having had to do the American board exams twice to get there. That didn't put you off.
Exactly.
So
didn't put me off. I liked it so much the first time I wanted to do it again.
Absolutely. And I got my European diploma without having to do an exam. I got grandfathered in. I was lucky because I was this side of the pond where it was all that much newer. So it's a great pleasure. It's lovely to catch up with you. It's been a little while. Usually I would have thought in the sort of space that we've had COVID, we would have met up at a conference at some point. And the other thing I should have mentioned about Gary is this great book, which is coming into a new edition. So don't rush out to buy it just yet, because there's a new edition. I know that because I'm supposed to be writing one of the chapters on it. That's my Christmas gone, that I have to write that chapter. But
short and sweet.
It probably will end up very short and sweet, but it's a great book. And I'm not just saying that because I'm writing that chapter. It's been a brilliant book, the last few editions. It's a very practical guide to dealing with behavior problems. And so if you don't know the book, what are you doing? So welcome, Gary.
Thank you. Glad to be here. Or there.
Yeah, well, yeah. It's.
I wish I was there. A little bit of travel, a little bit of visiting, seeing some people.
Yeah.
But working from home.
Yeah, absolutely. And you're welcome here anytime. So, I mean, I guess I don't know where to start with this. Maybe we ought to explain a little bit what CanCog is, because I said CanCog and people might think, "Ooh, what's he doing in that sort of environment?" And I've seen the setup there. The animals have great welfare. Do you want to tell us a little bit about the history of CanCog? Because I mean, I sort of know it by association, but yeah, I don't know the beginning. So you can tell me about it.
Well, I haven't been involved from the beginning, so I know some of the history. In fact, maybe I'll start with my history with CanCog, because, somewhere in the 2/3 or middle part of my career, I started getting more and more interested in the field of cognitive dysfunction. And I'm a little off topic to get you onto the topic. Also tells you a little bit more about my involvement. I did have a 12 or 13-year-old dog at the time who probably had signs of what would be aging, dementia, cognitive dysfunction. We can talk a little bit more about that and some of the signs. And around the same time, they were developing the very first new product, which happened to be through a Canadian company in Montreal. It was Deprenil Animal Health, and the product was selegiline. Or Deprenil at the time was the generic name, L-Deprenil. And it was being assessed for brain aging and cognitive dysfunction. And they had started doing it with a laboratory model that Dr. Bill Milgram and his graduate students had set up at the University of Toronto. Bill was a professor at U of T at the time in neuroscience, neuropsychology. I'm not sure of his exact degree, neurobiology, neuropsychology, PhD, and had set up some models based on some primate and other models called the Toronto General Test Apparatus, which was just a way of putting food out under different bowls for dogs and seeing if they could remember where the food was. I won't go into all the different tests, but there are reversal tests, there are memory tests, there are small and large objects, there are landmark tests where the dog has to go to the one that's the tallest or most pointy type of situation, or the object that's closer to a dish. And all of these were found to be declining in the senior pet. Young pets could do the more difficult tasks and the more difficult learning and the more delayed memory tasks better, faster, quicker than, or more completely than the younger pet, than the older pets, I should say. And that was a model that Department of Animal Health had decided that they could test in that environment with beagles to see if it did improve learning or memory tasks, and it did. And then being a Canadian company and having clinical trials going on, I was involved in that very first clinical trial, very aware of, including one that was on Cushing's, but that's a whole other issue. And got involved as a consultant for Bill and CanCog because very shortly after that, they decided that these models they had developed, in fact, as models for human brain aging. In other words, the dogs would be models to assess human products, human medications, could be used for models for animal, dog brain aging. They were models for themselves, and developed CanCog first with some work with University of Toronto and then a separate facility where they had dogs and cats that could be assessed in these models. First, initially on the various brain aging and dementia models, the product BD, which is a Hills food, which was developed from a number of mitochondrial mitochondrial cofactors, antioxidants added to the food, fish oils, was actually probably the first project that went on for several years at CanCog, looking at improvement in learning and memory with that brain aging diet. So that's where CanCog basically started. It was first dogs. It was primarily cognitive dysfunction and brain aging, so CanCog. And later on, it started with one of his graduate students, Joseph Ferruggio, and later on developed cats and expanded. And I was a consultant with them, an advisor with them for the first few years. And then as the years went on and I got out of general practice and more into behavioral practice and more extra time to do some work, I actually started working part-time there. And then when I left the behavioral practice, more, I wouldn't say full-time because I have multiple jobs, but more in a full-time capacity. And in doing that, I also worked with them to develop, as you mentioned, the anxiety models, where you can see the dog's response to a thunder recording, or you can see the dog or cat's response to a car ride, and see if the anxiolytic medications will reduce that. And this is a way of using small numbers, placebo-controlled, naturally occurring models, and non-invasive techniques to assess therapeutic products, often natural products, sometimes medications, sometimes foods. So there's a summary of what's going on. They also have osteoarthritis models. We have some cats, and that's the story of CanCog.
So I actually remember when I was in practice in '93, my boss at the time went to a talk, and I think he must have gone to WSAVA, and there was a talk, and I don't know whether it was by Bill Rule or whether it was by you, but he came back and he told me about this drug called L-deprenyl. And the next year I was asked to talk at BSAVA, and it was the first time I ever had to speak at a big conference. I'll tell you the story of that in a minute. But, you know, because he'd come back from this conference with this bit about L-deprenyl, and I realized then that it was also selegiline. I mentioned selegiline in my talk in '94, and SIVA, who Sanofi as they were then, sort of thought, hang on, how do you know about this drug? Because we haven't launched it yet. And, and that actually sort of launched my career. So it was just by that chance, you know, that sort of chance fact that my boss had gone to this talk. So there was, it must have been 93, I think, that that happened.
You might want to
Um,
mention, by the way, just to fill in the
yeah,
story, that yes, I'm sure that was Bill Rule. I wasn't talking
yeah,
probably till close to 2000 on the products, and I actually did more of the talks, presentations, and some of the writing into the BD type age. By the way, the end of the story with my dog, because I started it and I
yeah,
want to remember to finish it. Her name was Grace at the time. In fact, the chapter that I wrote in Decoding Your Dog, which is the American College of Veterinary Behaviorists book on behavior for the public, was called Growing Old with Grace. And it actually has a story, the story of Grace, because at 12, I remember one day sitting in our family room watching some television, and the dog, she was a Nova Scotia duck tolling retriever, so she would whine a little bit and do this sort of dance that the tollers sometimes do. But now she was doing it randomly almost all the time. And we've got this whining dog in front of the TV in the evening, and my wife turns to me and says, "What does your dog want?" I still remember going that way. And I said, "Yeah, there is something wrong here. She's getting older. She's got a little bit of arthritis. She's got some thyroid problems, but nothing other than what seemed to be brain aging." And right at that time, I got to try Deprano, which my wife, using that story again, Susan, called the wonder drug. She says, "I hope they have drugs like this when we get older." And this was many, many years ago, probably late 90s. Because it just made her more aware, more alert, and then later on BD for about a year. So I kept that dog healthy and wise, so to speak, for another 4 or 5 years because of medication and advances in the field.
yeah.
Then you were involved, as the story went, with the drug that had the same generic name, but had a totally different application and licensing over in Europe. And I remember also having to give some lectures and talks internationally where over here it was cognitive dysfunction, and over there it was a term they used, emotional disorders. And was that your
Involute.
scale, or was that Danny
That was
Patrick Pajot's
that was
scale?
Patrick. So Patrick had the EDID scale,
Yeah,
and that was the thing because I was involved in the licensing of Selegiline.
right.
And one of the things that the agency wanted to know was, what does this mean? And I said, well, there is this scale. And actually, and because I'd also been involved in translating Patrick's book into English, I knew French literature quite well. And there were quite a lot of studies that he'd done in order to validate it. But, and even to this day, people outside of France just don't get how to use that scale and understand it. So it's the evaluation of dogs' emotional disorders, or EDID scale. And yeah, it's in your third edition of your book,
Yes,
isn't
it
it?
is.
And I don't know if you're going to have that chapter in the new
Well,
one.
actually, that's why we asked you to write the chapter, so you could talk a little bit about terminology and scales that are out there, because otherwise it probably won't be in the
Okay.
book. So now
Um,
you know why you were invited to get some of those scales in there that you know
okay.
about. And exactly like you said, North American behaviorists just aren't aware of your own
Mhm.
scales. The EDED, he also has an RCAD scale for
So
cognitive age.
I can tell you, actually, hot off the press today, I've
Yeah,
just been finalizing the electronic versions of our scales so that everyone can access them free and get
excellent.
their own animals scaled. We've just got to sort out a couple of little glitches on the IT, so that will be out there for everybody. So we have the canine frustration questionnaire, we have the dog impulsivity assessment scale, we have the positive and negative activation, which measures sensitivity to rewards and sensitivity to aversion. And then we have the Lincoln Canine Anxiety and the sound sensitivity scales as well, if you're particularly interested in that. And they're just going to be available free to everybody.
Just so I can make the point, if you don't help to describe those in the North American books and literature, then they'll be out there with a European audience. So
no,
that's where we have to keep being
yeah,
international in what we do.
absolutely. And
Yeah,
and that is one of the things. I think yeah, that international. That when I started off, and I had a researcher, Jill Shepherd, and she went round and she interviewed people with the terminology, and it just became so apparent that people were using either the same words differently or different words to describe the same thing. So yeah, you mentioned cognitive dysfunction, and in France it was involutive depression.
right.
and in the UK, we didn't know what it was at that point. I don't think we just thought they're just old dogs. And there's still a lot of people who get confused between, well, it's an old dog versus it having cognitive dysfunction and that sort of issue. And there are scales, and the one for cognitive dysfunction that I recommend is Hannah Salvin's one. I don't know if that's the one you recommend, but Paul McGreevy and Hannah Salvin in Australia developed. That's the one I like for measuring whether or not your dog really does have cognitive dysfunction.
I actually use the one more frequently because North America, we're a little bit more familiar with this DISH format, with disorientation, social interactions, house soiling, and sleep. And there's a validated one by Aladar Madari and Norbert Zilka out of Slovakia. And that's the one that I tend to use a little bit more, although we've expanded on it in one of our trials because we are less interested in, I'm saying it wrong, but we're less interested in the diagnosis of cognitive dysfunction as the screening for cognitive dysfunction. And because of that, we use questionnaires that have a few more questions in them that might not be validated, but can pick up signs perhaps earlier. So yes, that's a great questionnaire, probably one of the best for validating the diagnosis. For screening, I tend to use the DISHA one or the DISH one a little bit more. So just for those who are interested.
So while we're chatting about cognitive dysfunction, and just as you had a dog, I had a cat with cognitive dysfunction, Rosie, the first cat Connie and I had together. And she ended up, wandering around the house, yowling away. And I just remember you telling me the story, and I think it was Kelly Moffat, and trying to get the work published there. And this is worth chatting about because,
yes.
People who are listening in, this is one of the problems with trying to do research. And I remember you telling me the story that it was Kelly's work, wasn't it?
Yes, it was.
So when you've got a problem like cognitive dysfunction and you're trying to evaluate treatments for it, you obviously want to screen for the cognitive dysfunction. But the problem is old animals have a lot of other problems. And trying to rule out, and things like chronic pain can present like cognitive dysfunction. I'll let you tell the story.
Well, no, that's exactly right. And two things were happening. Number one, finding so Kelly and I were doing together the screening of cats because both of us, and that's another story that we could talk about or not, I was in clinical practice for many, many years. My behavior was always an adjunct or add-on, or eventually became my primarily out of clinical practice that I was doing. So I had cases and owned my own practice, and Kelly had cases because Kelly still was my former resident, a behaviorist for many years right now, also has always been in clinical practice doing primary care as well as behavioral care on a referral basis. And we both screen cases. Using an expanded screening questionnaire like the DISHA that we're talking about, because of course we don't know what signs exactly we're going to see.
Right.
We both as practitioners ruled out pain, ruled out sensory problems, but couldn't completely rule them out because, as you said, what 13, 14 or 16-year-old pet.
3, 2, 1, you tell the story.
Sure. Kelly Moffat was my resident actually in Arizona, and through a close friend, colleague, and her supervisor at the time, Lowell Ackerman. I don't know if you know Lowell, he's a dermatologist and was involved in the clinic and originally from Canada, had asked me to come down and do the residency, mentoring with her. She was my first resident, successful veterinary behaviorist, but both of us were in clinical practice. And to do, as you well know, and I guess we can mention, any residency program needs a research project. So fortunately, to go along with the story, we did 2, because this project, as you implied, was never published. And the other one was the project was, she was in clinical practice, I was in clinical practice. We both did our behavior in the same way, where we were primary care practitioners and did referral practice and saw cases in addition to our primary care practice. Therefore, we, like dogs, decided that in cats, there was certainly more than enough evidence, as you yourself mentioned with your cat, that they had a similar problem to dogs and people with aging and dementia. which is often characterized by many of the same signs, with vocalization being a major one and disorientation type signs. So we decided, as you said, that we had to rule out medical causes. But of course, what 13, 14, or 17-year-old cat doesn't have some concurrent medical cause? So it's also a little bit of fine tuning where we rule out potential medical causes, but we know they could be concurrent. We know they could be working together and which one is primary for the signs. So we were very cautious in doing our screening. I don't remember the exact numbers, maybe 150 cats between our two clinics. We used the disorientation social interaction questionnaire that I was talking about with a number of signs. We screened for those signs, and then as practitioners, we ruled out underlying medical problems. We did blood tests, urine tests, we did sensory decline, and we probably found about 20 or 30% of those cats that did have medical problems that could have contributed. We could have done MRIs, but we didn't have any clients who were willing or interested in participating, even though we had the funding, because it requires anesthesia and going to a center that had MRI. Anyways, we got all of the results. I think in the 11 to 15-year-old cats, it was about 30% that we had diagnosed with cognitive dysfunction and probably didn't have medical causes relating to those signs. It was up to 50%, which also makes sense in the older group of cats over 15. We submitted for publication. We got good reviews when we presented the information at behavioral meetings, and yet based on probably three issues. Number one, we were defining a disorder, which clearly that's what we were trying to do, that didn't exist. So we couldn't publish in the literature because the very article that we were writing, publication we were writing, and to admit, two of the people who were looking at that field primarily were unable to publish for that reason. Number two, they didn't have MRIs because there were neurologists and others who were looking at it and wondered what the MRI might have shown. By the way, we had followed these cats for over a year by the time we published. So we knew they didn't have primary neurological disease because it wasn't progressive in that way, and they didn't have any correlating neurological signs. And because they had some concurrent disease that couldn't entirely be ruled out, we never published that paper. The disease is, or the disorder is known in cats to be brain aging, dementia, cognitive dysfunction. That research has been presented, it's been abstracted in places, it's been referred to in the literature, but there hasn't been a paper, I don't think, since that has actually looked at prevalence of cognitive dysfunction in senior cats, although people like Danielle Gunn-Moore have published some work using that literature and that type of questionnaire as the basis for their research. So there it is, cognitive dysfunction in cats, with a publication that's never been published.
No.
But a resident who's board certified now and practicing in the field because she had another research paper to publish.
So what was her published paper then? Because I remember her.
It was on vocalization in the veterinary hospital.
Oh,
so,
okay,
yeah.
nowhere near as interesting as as the cognitive dysfunction, but
we had the cases coming in and we could assess the vocalization, so it was a quick and easy one that we could do that wasn't anywhere near the interest, but we had to have a publication as a backup. So in any case, I've had 4 residents now, all out of clinical practice. Only one who actually worked with me in the practice, which was Dr. Sagi Denenberg, who actually now also teaches part-time at Bristol. So he's working here in Toronto and seeing cases in Bristol once a month, pre-viral pandemic, and by email, phone, I guess, telemedicine now.
Yeah, I mean, we're doing quite a lot of remote consulting now, and it works really well, I think, for some cases. Obviously, sort of the medical workup, you're much more restricted, but I've been pleasantly surprised how things have gone there, and clients like it. And some of the coaching we can give owners, I think they're a bit more relaxed in their homes, and it works better from that point of view. But
admittedly, sometimes when we have fairly aggressive pets, very fearful pets, we can't do a full physical examination in any case during our behavioral consultation. They are done by the primary care practitioner, or they're done under sedation by the primary care practitioner. So we're really observing the pet, the owner, some examination, some interaction. So there's a fair amount that we can do with telemedicine, and not to mention the fact that if they want to carry their camera around, we can see their home a little bit more than we would normally be able to see it. So the environment that the pet lives in,
Yeah.
as you said, they're more relaxed. And for somebody like Dr. Denenberg, who lives in Toronto and works at Bristol, it's a lot easier to do telemedicine.
Absolutely. I mean,
it's actually seeing more cases because of it.
Yeah, no, I find it amazing how he shuttles between the two, but no, it seems to have worked well for him from that point of view. So I have to ask,
that was one of my big goals, was to get more residents in the field as board certified behaviorists through the clinical practice route, because I was not academic and didn't have an academic facility. So on 3 of them, I had to fly to other locations to mentor them in their own practices. And with Sagi, he did it in Toronto, and fortunately all of them board certified, strong, important parts of our profession now.
Yeah, no, that's good.
And I'm sure, I know you've done many more in your facility, but
I've only done,
it's important
to
grow the field.
I was chatting with I can't remember, it was I think it was with Bonnie Beaver, and we're saying how there's been that drift in North America, that there's very few residency programs now in the universities. And our residency program is a non-conforming one because we're not a vet school. And although I have a visiting position at Nottingham, and we can use the facilities there, every resident has a bespoke program made up for them. And the European colleges started to say, well, we know that how you do it, so why don't you try and get, but it used to be that you had to be in a vet school to have a bespoke. It's and it's interesting because I think it's a different profile as well, because the sorts of cases we see, as you know, we see so many cases where we see chronic pain, and I just don't know whether or not, as I said, it's because we're a referral and because we have a particular interest, we're seeing it. And it's because it's not being picked up, that's why we're seeing it, or whether it really is there in the population at such a high level. I mean, I don't think it's, as I say, last time Kevin looked at his caseload, it was 80% of the cases that he'd seen had some sort of chronic pain or involvement, which is a bit scary. But it's why vets need to be doing this. Absolutely.
Exactly.
And people say, oh, well, he's been to the vets, I know he's okay. No, afraid not.
Specialists, referral specialists, people who are advanced in the field have a different level of knowledge, have more skill, more expertise, more experience in the field. And, that's why the specialty field is so important in human medicine and veterinary medicine. Having said that, even if there could be more of these conforming residents, as we refer to them as, or university residents, I doubt there's more than 8 or 10 schools that actually have the residencies. And now, because the American college residency and program is several years older before the European, I don't know if the number's up in the 40 or 50 range, maybe even higher, of residents in the American college right now. So you can see how doing it in clinical practice can really grow the field enormously.
So one of the things I've missed not meeting up with you is the chance for us to swap our slides. Because that's again something which, again,
you mean physical slides? I've got them on the floor here. I know, somewhere.
Yeah, I've still got
glass slides.
Yeah, I've got the glass slides. God, yeah, in those days you had to prepare your talk several weeks in advance, as opposed to sort of during the next speaker. Still editing it, but I forgot what I was going to say.
Sharing slides.
Yeah, we were talking about sharing slides. Because when I share your slides, I always sort of look at them and think, oh, didn't know that. So what's your latest best recommendations on cognitive dysfunction before we move on to something else as far as treatments go? What if it was your dog again, if it was Grace again, what would you go with?
I think that we don't have strong treatments for cognitive dysfunction, aka Alzheimer type disease, for obvious reasons, because I think that the species parallel each other, that when there are advances in one, there's likely to be advances in the other.
Yeah.
Although we can give probably more early support and the disease doesn't advance as far in dogs. And most of the products are nutraceuticals. There just haven't been the licensure, maybe costs, maybe number of cases. I don't know why, but the drugs aren't out there. Again, probably because the human drugs are in development and not ready for animals. With that in mind, I would use SAMI product. I would use dietary supplements. The ones that the one that we just tested a few years ago in a clinical trial was the one by Purina, which has the MCT oil in it. So it's called NeuroCare, but has a 5.5 or 6.5% MCT oil, which gives you ketones in the.
Just so people who don't know, MCT is medium chain triglycerides. Yeah.
Exactly. And they're supplemented in the food, and they provide an alternative form of energy to the brain, to glucose, ketones as a form of energy. So there may be some value to diets that have multiple ingredients in them rather than single ingredients. So I still like that product that I mentioned, which was BD, whether it's the brand or not, which has fatty acids, which has mitochondrial cofactors, which has antioxidants in it, so that you're getting multiple factors influencing the brain. Even the NeuroCare diet that I mentioned that has the medium chain triglyceride, the MCT oil, has mitochondrial cofactors, fatty acids, B vitamins in it. So it's these multiple supplements. The only drug is the selegiline, although you have a couple over in Europe that we never had here, and I don't know how you feel about the propentaphyline and the isergaline.
Yeah, I mean, they certainly sort of buck them up a little bit, but whether or not they're that good for cognitive dysfunction, don't know. Nisergaline, I think that could help. But
and we've had some fairly good moderate to good results with some cases with the Senalife product, which is a multiple product with phosphatidylserine out of Seva, and the Activate product, which also has phosphatidylserine in it. So those are the ones that are out there, not necessarily one better than the other. You've got to try that blend that works for your pet and look at the clinical improvement.
So what, a few years ago, I was at one of the CanCog meetings, and there was this big buzz about this jellyfish thing, apoquarin. Yep. What happened to that? Did that?
It
seemed to suddenly appear, and then there seemed to be quite a lot of buzz about it. It was calcium channel blocker, wasn't it?
Yeah. There's a human product called Prevagen, which has a lot of press in North America. Some of these natural supplements don't get into other countries for a variety of reasons. We can't use the Prevagen in animals because it has vitamin D in it, and it would be too much to use the same dose. But it was called apoecorin. It was a jellyfish protein, and they had a veterinary version of it. And for business reasons, I believe, the company that provided the human product discontinued the veterinary division of their company, so that it was a pretty effective product. When we talk about it relatively to the other ones that I mentioned, there was some good effect in some animals, but just not available anymore. So but I don't think it worked any better than the ones I mentioned. It was just another mode of action, another mechanism, and you could use these synergistic or additively, I guess, as well.
Yeah. And so, the other thing I just wanted to pick your brains. Did you see those recent papers coming from the Vienna group about the dietary supplementation, because they were working with pet dogs? They didn't see the boosting effects because they reckon that the enrichment that a pet dog gets in its normal environment, you weren't seeing the same boosting. Did you see those papers or not?
I think I've seen them. I don't recall them exactly, but obviously it depends on the group of dogs that you're dealing with, the population that you're dealing with. The NeuroCare trial that we did, the trial with the MCT oil, was strictly a clinical trial. They had done laboratory trials on the MCT oil, laboratory trials on the brain protection ingredients in the diet, but this was a clinical trial, and it did have clinical improvement, although there was huge placebo improvement as well. So yeah, tweaking that out is very difficult. Anytime you enrich the lives of senior pets, you're probably going to enrich the brain. And as you well know, even doing a trial is sometimes more intervention, more interaction, more observation of the pet, and that alone can change behavior. So I'm not surprised. I don't know that it doesn't work. I don't know that you can't necessarily see the effect because it's not strong enough. So.
I mean, and I remember with the BD diet, you know, the big effect was the diet plus enrichment, and that's the key thing, getting it there. But
at that point, when they did that research, there were a lot of follow-up studies when those dogs passed away, and they did see some fairly significant changes in the brain in amyloid levels, antioxidant levels, etc. So whether it was causing outward improvement in behavior or not, there was definitely some pathological improvement after using that diet. But as you said, the enrichment group plus the diet group had the most behavioral improvement.
Yeah. Okay. So let's move on. Let's talk about something other than old animals. But that's actually quite nice because I'll try and get Thomas to section that bit out because I'm sure there's loads of owners of old animals who'd like to hear. Fear-free. Let's talk about fear-free because that's a really big thing in North America. I don't think it's taken off to the same degree in Europe. You might say otherwise, but certainly in the UK, I don't think it's taken off to the same degree. But just again, if people don't know what fear-free is, do you want to say a little bit about what fear-free is first, and then you talk about the sort of impact you think it's having in practices?
Well, as you know, I know, and every behaviorist knows, as well as many, many practitioners, that fear of the veterinary visit, fear associated with veterinary care, the anxiety, the stress for the pets, and to some degree for the owners, is a welfare problem. It impacts the level and type of veterinary care that we can provide, the completion of procedures. The animals are going through the pain and discomfort of the stressors of visiting a place that they're frightened of. And like I said, the owners are stressed. There's also safety issues for the veterinarian and staff when it comes to dealing with the pets. And there's a reason that whether it's veterinary medicine or human medicine or even your barber or your dentist, that everything we should constantly be looking at reducing fear, anxiety, and stress, and even preventing it when you come in to see a professional, when you come in for to the person who's supposed to be caring for your health and behavior, and unfortunately is causing more stress and distress for that pet by the visit and the procedures that we do. They're going to be a little bit uncomfortable. The pet's going to be ill when they come there. Clearly, the pet's going to be painful a lot of times they come there, but we don't want that associated with the veterinary visit. So as behaviorists, we've been talking for years, this is not a new thing at all, about ways to reduce fear, anxiety, and stress in pets, for the pet owners, for the pets, whether it's in the home or specifically in the veterinary clinic. Well, to come full circle, a continuing education course program was designed and developed by Dr. Marty Becker, who was looking at the emotional distress of the pets and saying, we're the people who should be improving the welfare of these animals, and we're harming them every time they come in, or they're not getting the care they deserve or need. And because of that, we need to address this, and we're going to put a program together to address this, and a continuing education program that uses behaviorists as the foundation, that uses anesthetists and pain management specialists to put those sort of products and drugs into the program to reduce fear, anxiety, and stress with medication where you can't do it preventively and behaviorally. And basically, a course was put together with 8 different modules and continuing education online to support it, called Fear Free. Began continuing education at the conferences with Fear Free, so it's a company, Fear Free LLC, and most of the behaviorists in North America got behind it as advisors, as speakers, helping with the course, helping with the continuing education, and it's grown hugely. There are 3 different levels for the practitioner online signing up for the fear-free certification program. There's many, many add-on modules and courses on pain and fear-free, on dermatology and fear-free, on end-of-life care and fear-free. I think people just don't realize sometimes the extent of the program and the amount of education. It's also supported now by an online resources called Fear-Free Happy Homes, which is entirely free around the world. So if veterinarians aren't joining the program, so to speak, or doing it in other ways, because there is cat friendly, there are stress-free programs, there are other programs that are available to practitioners to put this in place in their practice, formally, to get certificates in it and to learn the program. But Fear-Free Happy Homes is available. You do have to sign up for it, but it's completely free, and it has courses for modules and education and resources for pet owners, from home enrichment to reducing anxiety to reading signs of fear, anxiety, and stress, to getting to the veterinary clinic fear-free, low stress. There's also now a shelter program, Fear-Free Shelter program. They've now expanded to a program for groomers, all positive, fear-free, a program that they can for trainers, all positive and fear-free. It doesn't train you to be a trainer. It allows you to be certified in fear-free to help support fear-free practices. There's now avian, which has just come out as one of the modules within the fear-free program, and equine is in the works. So it's going to be multi-species. I think it doesn't have the international support because of the commercial aspect of the product. But, you know, as you and I both know, everything in continuing education is, other than government, is supported in some way by sponsorship, by funding. The meetings that you and I go to have, even the continuing education companies that give the meetings are companies. So I think there's a little bit of resistance when it comes to that. But if you get beyond that, it's the program that really educates you to apply and put protocols in place and train your staff and make your clinic low stress, positive, fear-free.
Okay.
And
no, I wasn't
all the
aware
different aspects of it.
Yeah, no, I wasn't aware there were all those additional things, the groomers and the trainers and the like. So we'll put a link on the site, sort of, so people can go straight to that.
Their mission, just because it says it all, is preventing and alleviating fear, anxiety, and stress in our patients and the people who care for them. So basically, it's all about training and by the way, in the certification course, the people who've taken the course and become certified, probably over 50% of them are veterinary nurses and personnel and staff who are the first people that see and work with the client and the pet and do a lot of the handling and the care. So it's all about the hospital, the care that we give, and because it's a big part of what I like to preach and talk about, using medication without hesitation when the pet is fearful and stressed. Don't feel that you want to avoid medication when the fear and anxiety is much more harmful to the pet, and the medications are going to relieve much of that.
I always remember Kendall Shepherd saying to me, that if you took your dog into the vets for a vaccination, it came back with a broken leg, you'd quite rightly be really annoyed. Yes. So why do people accept the fact that they take their dog into the vets and it comes back, damaged psychologically just as badly? Yes. And it is such a big issue. But I've just been amazed how it's sort of taken off in the US. We're just not into that. Anything taking off in a big way in the UK, I guess.
Well, you know about cat friendly and feline friendly, and there is that for cats, but there's not that advocacy for dogs. So this program covers all species, but it's a matter of, if you can, and you can prevent, you can alleviate, you can reduce, But when you have to treat that pet and it's fearful and anxious, there's also great medications out there that picking the right one for the pet can really alleviate their stress just for the moment. I mean, we're not talking about behavior problems and behavioral disorders where you would need strongly supportive behavior modification plans and ongoing medicine. We're talking about situational medicines plus the environmental and behavioral support for travel and for veterinary visits.
Yeah. I keep looking away. If people are wondering, it's not that I'm losing interest. I'm just writing notes of when times are so that
Got it.
that Thomas can go and splice it all, hopefully, into smaller bits for people. Because some people like the long thing.
I think there's a reluctance, I understand, in some countries outside of, there is in North America too, but in countries outside of North America for the use of medications in these sorts of situations, which kind of surprises me, because if you're suffering with pain, you take pain medication, and if you have diabetes, you take diabetic medication, and there might be other supplementary things. But if you've got fear and anxiety, why aren't we taking fear and anxiety medications?
Well, and if you can't examine the animal because it is so scared, then you're compromising the healthcare that you can provide. So it is really important.
Exactly.
And that's where the medetomidine gel can be really useful as well, because it's that short acting. So again, you're not going to get the hangover. And yeah, I think people are still hung up on the idea that psychoactive medication just sedates, their animal, and it's so much more sophisticated than that. So
you're exactly right. And the dexmedetomidine gel, there was actually a presentation at our behavior meeting this summer where they not only could you use it prior to the travel or prior to the visit. In this presentation, which has now been published, they actually gave it when the pet arrived, and then waited to 20 minutes and then did the examination and the procedures at that point, because it works that quickly. Yeah. So you've got the dexmedetomidine gel. I put up with, talk about practice what you preach. My current dog's name is Pepper. She's a 6.5-year-old Havanese that I'm surprised isn't barking at us or jumping on my lap right now. She's very attached and loves us being home even in this pandemic. I wouldn't say she has separation anxiety, but there she's going in the background, but she loves to be with one of us at any time of the day. She also, because I was a veterinarian and had my own practice till a few years ago, would come with me to the veterinary practice and loved coming to work with me. So she likes the veterinary clinic. She likes the groomer. She likes the environment. It's fantastic. But we don't like traveling with her. Probably because she doesn't like traveling, because she whines and she digs, and I think it's excitement, but there's definitely some anxiety there. And because shoemakers' kids, practice what you preach. I put up with the 15-minute drive because she liked it there and she was fine coming home, and that was it. Also good coming home. So I think it's the excitement and conflict and a little bit of frustration about getting out of the cage. Anyways, 2-3 times ago, I decided I was going to try trazodone on her, which is one of the drugs we sometimes use. It's an off-label use for pre-visit situational medication. I used a very low dose because I was careful, didn't do a thing. And the next time I used an adequate dose, and she went into the car 2 hours in advance or so. Then she went into the cage in the carrier in the car, lay down, put her head down, made a little rest and a nap for herself, and just relaxed the whole way there. Got up, jumped up when we got there. Yeah. So it's not causing sedation, but it's causing enough calming that we had a pleasant car ride. She had a pleasant car ride, and it's worked consistently the last 3 times, because I'm waiting for it to have been a placebo effect or not work, but it's working just fine. So don't hesitate. These drugs don't necessarily, as you said, sedate. They calm and they overcome that stress and anxiety that none of us want to feel.
Yeah, absolutely. And I think it's about making, and you can't always get the right dose first time as well, and you've got to be prepared to be patient if that's the issue.
And to finish that topic, my role in Fear Free was on the executive council, just for disclosure too, and then on their advisory board and on their speakers bureau. But I have a contract position, and all those still do some of that, but all of my contract position is I'm the head of their research. And I'm mentioning this for a reason, because number one, there's a great research page on Fear Free where we have collated bibliography of pretty much as many articles as I possibly could find in the research field related to reducing fear, anxiety, and stress medications of veterinary clinics. So you can go there. It's fearfreepets.com, but then it's the research page. And they also fund in small amounts research each year related to reducing fear, anxiety, and stress. And the projects that we funded are up there. The projects we've given awards to. You may have seen a couple of awards we've given at some of the meetings for projects related to that. And there's a call for submissions for new projects on that site, which is why I wanted to bring it up in case there are any veterinarians or would-be researchers out there that would like to know about small research dollars. It's not limited. One of our research projects now is somebody who's looking at, it's up on this. Once we approve research, we put up what we've got funded or the results when they come in. So we do have one that's funded now that is a little delayed with the pandemic, but it's classical music and valerian used for veterinary visits, and it's being done out of Italy. So they applied. They were the ones who won or got awarded the last grant, and encourage people to submit and look at the research, because everything should and can and should be science-based, evidence-based, as we both preach and know.
No, absolutely. Okay.
That's
really
Fear Free.
That's good to go. The other thing I really wanted to chat to you about, and this is something which goes back quite a long way, but I noticed that you've recently published a chapter on it, and that's psychogenic conditions. And because I know we've chatted about it, and I think it was in the Vancouver meeting that you first presented a group of cats which have been presented for psychogenic alopecia, and they had, because Steve Weisglass, was it Weisglass? Yeah, he's a dermatologist, so he really went at them from a dermatological point of view, and there wasn't an awful lot left for you to work with after that. But
that's for sure.
Psychogenic, well, not just alopecia, but psychogenic diseases. I haven't read. I must confess, I haven't read your 2020 publication on it. So this is I could have been reading it tonight, but I'd be rather chatting to you. So tell me what's going on.
Well, I've sort of transitioned a lot of my writing and publishing to residents or new diplomats. So although my name is on a lot of the chapters, and I've supported the research in the chapters and provided them with the references, the one in the feline dermatology book and another one we just recently were done by co-authors, and very well written, and lots of new material, because the new graduates and the new residents and the new diplomats have the new research. But with that in mind, again, I have, and you've probably hit all three of them, 2 or 3 interests that I've kept up and that have been some of my primary interests in behavior, with the cognitive dysfunction and reducing fear, anxiety, and stress. Of course, not just in the veterinary clinic, overall in pet health and behavior, but psychogenic and medical differentials for behavior problems as a broader category has been a strong interest for many years for a bunch of reasons. One, cognitive dysfunction. I mean, you got to figure out what medical problems might be involved with cognitive dysfunction, just as you discussed with behavior now, and the big focus of pain and behavior that you're looking at. The second is psychogenic diseases, or diseases that could be behavioral, but you have to rule out the physical problems first. So, and then the third reason is I was in clinical practice, so I was always focused on ruling out medical problems. And I think one way that we have to do it sometimes in pets is to ask them by trying a medication, what you would call therapeutic trials. So just like you perhaps, or we perhaps as behaviorists might use pain medication when we suspect underlying pain might be contributing to a behavior problem to see if it improves. We do the same in many different diseases, including cognitive dysfunction and including these psychogenic diseases. So I was working with my partner at the time in the behavior practice and dermatology practice. We only had two specialties in our practice, behavior and dermatology. Steve Weisglass, just so our stories commingle, was my partner in the veterinary practice, ran the referral practice with me. He did derm, I did behavior. And remember the name Lowell Ackerman from an earlier story. Lowell was the supervisor of residents at the practice in the States, but he was a board certified dermatologist. And when he was in Canada and about to move down to the States, he undertook Steve Weisglass as his resident at the time to take over the behavior work in and around the Toronto area, and then got board certified, of course, and has had his own residence since then. So his project at the time during his residency was to work with me on cases of cats that were coming in that were licking their hair off. By the way, I don't even know if you're old enough to know that a lot of many years ago, it was often referred to as feline endocrine alopecia, thinking there might be some sort of endocrine underlying problem, and not realizing that cats are closet lickers sometimes and lick in privacy, and their hair wasn't falling out. Not that there couldn't be an endocrine problem, there rarely can be.
No, that's what I was taught. That's how it
Yes.
was.
Yes. But they're licking their hair out.
Yeah.
And that hair is clearly either being licked out because they're itchy or because they have an underlying stress-related behavioral problem. But how do you ask the cat if it's itchy or not? And too many of them, we felt, were being automatically thought of as psychogenic or stress-related because all cats have some stressors. We all have stressors if we look for them, but is there a cause and effect? So we decided to take up to 25 cases, again, some underlying seed funding, to work up any case that the practitioner in the area had diagnosed as psychogenic alopecia. The cat was licking its hair off, and the practitioner had done as much of a workup as they could to reach that diagnosis. We didn't define that. In any case, to get to the end result, I did a behavior history on every case. Then I sent it down the hall, so to speak, to the dermatologist, or he took over the room and I left the room, more specifically.
Great practice. You don't have much out of hours if you're a dermatologist and a behaviorist. That's great.
Exactly.
That's great.
So he took over the case and did a medical workup. We won't go into the details, but if you ask me a test, I'm sure we did it. He also did some hair analysis and some skin tests. He then, if all the tests were negative, didn't see fleas, didn't see parasites, put it on a flea medication in case it had a flea hypersensitivity, put it on a food. At the time we used hydrolyzed protein, but a limited antigen diet to rule out an underlying food cause. And if that didn't clear it up in 8 weeks, we gave them some steroids. Why did we give steroids? Because the way I always put it is we have to ask the cat if it's itchy. And the only way to ask the cat if it's itchy is to give it something that takes away itch. And lo and behold, I think the number was 15 out of the 21 cats, no, 16 out of the 21 cats that cleared up with any one of 2 or 3 of those treatments, either with a food trial or with a flea control trial. Even though we didn't see fleas, these pets with flea allergies are licking them all off, flea hypersensitivities are licking them off. Or they're not on the cat when we look at it, or they cleared up with a steroid shot. By the way, looking back at the history from all these practitioners that had diagnosed psychogenic alopecia, they had in their records many cases that the cat would clear up for 2 or 3 weeks with a long-acting steroid, but then it kept coming back again. And I'm being a little sarcastic and facetious when I say this, but steroid shots don't clear up psychogenic alopecia. I mean, that was the clue, that should be the clue right there, that these were itchy cats. And if we look at a study, I think it was maybe last year by Titu out of France, feline head and neck scratching, ulcerative dermatitis, they cleared pretty much every one of those cases with stress management, with behavioral management. So that both of these problems could have an underlying behavioral cause, as could acrylic dermatitis in dogs, or lick granulomas, whatever the best term for that is, as could many other nail chewings and self-traumas. But we have to rule out the medical problems first, and some of them are repetitive compulsive disorders that the behaviorist then needs to treat quite intensively, because they are not easy to control. We can control them, we can't necessarily resolve them.
Yeah,
the compulsive disorders.
I don't know if you know, let me tell you this, because I don't know if you know this, but one of the very first papers that I wrote up was on psychogenic vomiting in cats.
Right.
When I was a student at Bristol, actually, we had a few cases that came in, and a number of them were worked up, and I got quite an interest in it. And I'm just thinking about it now, because I just realized I haven't seen one for years, 20 years or more. But they were, when we sort of worked them up, they were all, that new breed of Siamese with the very sort of pointed face, as opposed to when I grew up, Siamese had quite round faces. We now have the traditional Siamese and the modern Siamese, and you just couldn't rule out that these cats actually had intracranial pressure, because at that point, the very narrow, languid sort of Siamese was really coming in. So, and I'm just wondering, I have to say, I just haven't seen it. I haven't heard anybody talk about it for 20 years. And I just wonder if, as the breed was changing and they were selecting for the different skull shape, whether it was an artifact of that. Have you seen any or heard of anybody talk about psychogenic vomiting in cats recently?
No, but no, I haven't, but they're actually on the same topic, were a couple of presentations out of the University of Montreal behaviorists looking at environmental licking. I don't know which is, same category of topics that we're talking about here. And they found not necessarily cause and effect, but underlying gastrointestinal problems in a large percentage of both cats and dogs with licking or picas that could be related. So you have to wonder if some of those cases were psychogenic, or whether they had undiagnosed GI disease or intracranial pressure, as you said. Of course, the other side of the story of all this, just to finish that story, is that when you do suspect a compulsive disorder, you sometimes, or repetitive disorder, stereotypies, you sometimes get a very good response, not full response, to SSRIs and serotonin reuptake inhibitors, clomipramine. So it can also be your therapeutic trial, but it certainly takes much longer for it to work. And it also could have effects on pain and other pathways. So therapeutic trials have become an important part of veterinary care.
Yeah.
And diagnosis.
With the pica in cats, after reading some of the stuff coming out of Diane Frank's group, we had a cat come in with pica, and we checked it for Giardia, and sure enough, it came back Giardia positive. Treated it for the Giardia, pica disappeared.
Exactly.
And this is a cat that had a propensity for light bulbs, little,
wow,
little. I don't mean sort of the main lights, but like the little Christmas tree type lights, and it would just chew them up. It's really bizarre. But
well, you've just come full circle back to the fact that veterinarians who specialize in behavior are essential for multiple reasons, but because we mentioned dispensing of drugs, et cetera, when they're indicated, but for the ruling out of underlying medical problems or contributing medical problems in all of these cases that we've been talking about for the last few minutes, including underlying pain. So it's so essential to get that workup. On the other hand, you kind of have to know your territory too when it comes to a specialist, and geography I'm getting at, because I could probably mention some conditions that are more likely to be behavioral than medical in certain breeds. And in speaking to colleagues like Kirsty Sexel or yourself, we find that breeds in other countries don't necessarily follow that same prevalence of disease or problems. For instance, when I see a Labrador retriever that's eating rocks in North America, I doubt it's an underlying medical problem. It's a Labrador retriever that's got a pica that's rock chewing. And I don't know if that's a thing in the UK or not.
Labradors just eat their food and owners give them the food. I don't see them particularly eating rocks, but I mean, anything that's rock eating now, I do wonder about gastritis. And of course, they got gastritis because they got rocks in their stomach. But
that's the point I was making, that I would think of gastritis first in most breeds, but in Labradors, I go, they eat everything, and at least the population that we would see. So there are certainly, I wouldn't say breed differences, but line differences within breeds as well, predisposition.
No, I guess so. We ought to, and that's something we ought to be doing more of. As you know, I've got a good friend in Brazil, and often we talk about the cases, and again, the profile that she sees of cases there are very, very different as well. And it's so easy just to assume that what you see is translatable right across the board.
You're talking about the colleague in Brazil who talked both of us into speaking at her conference. That colleague in Brazil.
So Daniela will probably be listening to this. So we better not say anything too bad about it. But Daniela Ramos, give her a name check. Lovely individual, works really hard. So we'll be giving that talk fairly soon. Now, you've sort of been telling me when I asked you to do this, you were very reticent, which was that's just your modesty, but you were sort of also saying, "Oh well, thinking about retirement." I can't believe you'll retire. I just, that means you'll go around the world and you'll actually stay with Susan, and rather than I'll go off with Susan in the gaps and go sightseeing with her. I mean, surely.
Retiring doesn't mean that I won't attend meetings and go to the continuing education. Retiring would mean that I would, when travel is available again, and we just got word that we're on the wrong end of the spiral. They just said to us today that we may be worse than the UK and some of the European countries in the next 3 to 4 weeks. We seem to be just a little bit behind. So I don't know when we're traveling again, but I do need more away from the computer time, more, and I've reached an age too where it's time to travel with attending the lectures, but not necessarily giving the lectures, and attending the lectures, but not having to retain it all, take notes.
You do know that might mean you have to pay to go to the lectures, though. That's one of the advantages of being a speaker. But
after you've been in practice long enough and for enough years and whatever, hopefully you've saved a little for your retirement just to do exactly that. So we'll see, but that's what I would like to do in the not too distant future when things open up. But in the meantime, I'm not even getting more than 20 kilometers away from home, let alone out of the country or on an airplane. So we're looking forward to visiting everybody again.
Yeah.
Including you.
Look forward to seeing, and you're welcome here anytime. So as I said, the things I really wanted to chat to you about was sort of, the cognitive impairment, psychogenic, and the fear-free. But I'm going to ask you this sort of, is there anything else, or what interests you most in behavior?
Well, those are the topics that interest me most, except for what I'm forgetting interests me the most right now. But with that in mind, my interest in behavior was always as an adjunct or part of clinical practice. I really felt that when I was first lecturing, first speaking, first writing, even the books that I write, the resources I was writing, the handouts I was writing, was to support the primary care practitioner, to do more behavior out of general practice, to add more services, because you can prevent or treat, and we can be doing a lot of preventive counseling. Our colleagues have done studies to show that a first visit with a behaviorist can prevent all kinds of, and that can be done by the practitioner, just the study was done with the behaviorist, can prevent all kinds of behavioral issues and behavior problems as the pet grows. Some studies recently to show that if the first visit is positive at the veterinary clinic, everything can go nicely from then, because the pet thinks of it as a great place. But it's all up to sometimes that first visit, giving owners advice early, intervening on diseases early we all know about, treating diabetes before it becomes ketoacidotic, or kidneys while there's still some kidney cells left to survive or to retain. We want to treat behavior before it gets advanced. We want to do preventive care services. So really, even though I'm trying to advocate for more residents and more behaviorists and more science in the field, I'm really advocating for the practitioner to learn more and do more. When I knew I was going to talk to you and trying to remember some of my past, I went back and looked on my bookshelf, and this book here called Pet Behavior Problems.
I've got that.
Was the very first book that Wayne Hunthausen, who was a practitioner, who worked with me in the field, well, he was in Kansas City. He and I wrote this for the American Animal Hospital Association, 1993 or 5 or something like that, before our first book that we wrote. And it's a practitioner's guide to pet behavior problems, and handouts and forms, the LifeLearn handouts I wrote. So again, I think it's really critical to educate and support and get behavior services at a good quality level, almost to a specialty level at the primary care practice, somebody in the practice doing it.
So I think you're right. And I think I've said this to a few people. I think one of the problems with veterinary behavior is it became a specialty before it became mainstream, which is completely the wrong way round, you know?
Right.
But, you know, vets have always sort of been trained in behavior, but it was assumed with companion animals that they were well looked after. So they didn't, you know, there wasn't a need. Whereas farm animals, oh, well, they had a problem because they had a farmer, and it was just that sort of elephant in the room. And yeah, so the specialism grew up where people were starting to say, well, look, you know, and it takes a long time to do this, and there's certainly, you know, historically been, I think, difficulty for vets charging for their time without dispensing something. And yeah, it's only now that we're going back, and I think to realizing that, yeah, so much of it needs to be first line. And in the UK, we've got a review going on with the veterinary profession, and it's the thing that you hear, you know, it's one of what we call day one skills. And when the vets graduate, the day one skill they know they need is behavior. They have to be able to handle those animals properly, because otherwise they're not going to have any clients to see before too long.
But you're exactly right. I just think that that's critical. And there's reasons for it. People would send pets off to trainers, but trainers didn't have the skills to do anything at that time other than quote unquote train. And all of what we're talking about, or most of what we're talking about, is guidance, is advice, is preventive. It's not the doing, it's the not the hands-on doing of training. How many times did we used to hear the dog's got an anxiety disorder, send it to a trainer? And you go, well, to train a dog to sit and lie down and come and recall. And remember, I'm not talking about current training or positive reinforcement, force retraining, educated trainers. I'm talking about this old style of doing things. Didn't treat or prevent the underlying anxiety problem or the underlying behavior problem. There was a study recently out of Chile, I think it was, looking at veterinarians, and the more experience they had in practice, the more likely they were able to read dogs' anxiety and aggression. Some of the younger veterinarians, and this was looking at whether they had training in the veterinary school or not, weren't able to identify anxiety on videos, or even some of them signs of aggression. So we're not just talking about advice, we're also talking about caring for those pets. Also, a recent study from a colleague out of a veterinary school looking at students' knowledge when they enter the veterinary school versus after their behavior courses. And it was terrible when they first came in, even if they owned a pet, or very low, I should say, and quite good when they left after their behavior courses. And yet there still is probably not enough behavioral medicine going on in the veterinary schools, at the colleges levels, at the continuing education level. That's why Fear Free is so very valuable. It teaches you to learn and recognize fear, anxiety, and stress. I think something like 22 of the 30 some odd veterinary schools in the States now require you take the Fear Free course as part of your undergraduate program, somewhere in that program. And by the way, just to help out, Fear Free is free to register and take the courses for students and faculty, so that it's not as if it's a money-making proposition, it's an educational proposition for them. So if there's not enough education at the veterinary school level, there should be more. And on top of that, there are the Fear-Free type courses. So again, that was my goal, to get practitioners involved in behavior.
Yeah. No, well, as I said, you've been a real inspiration to me, and that's one of the nice things also about doing these podcasts is, often we're running around, and and there's sort of, maybe because of lockdown, when I started doing these, I started to think, I really want to say thank you to lots of people, because I've been so lucky, and I've been so lucky to know you. You've been really generous to me. And yeah, so I really just want to say sort of thank you for all you've done. And well, you're not going to retire, not going to disappear in that sense, and I'll still be picking your brains in years to come, I'm sure. But thanks a lot, Gary, for giving up the time this evening. You seem to be disappearing into the dark as this.
Oh, wait a sec. I'll let them see me one more. I told you that when we started, that the sun was going to set and my room was going to get dark over time.
There we go. Now you can see.
It's 4:45 here, and the sun sets around 5, and the natural light is gone, and this is what artificial light.
I was going to say, because you got a black shirt on a black chair, so I was starting to just talk to this head floating in the screen.
I could see it, but I didn't really want to get up and leave without telling you where I was going. So you can see me to say goodbye. In any
case,
is
just an audio version of this, so those people who just listen to the audio version won't have the appreciation of that. But it sounds like your dog needs you as well. And as I said, thank you so much for this evening. It's been lovely to catch up with you. And I hope, as I said, we'll be catching up with you very, very soon, and give my love to the family as well. Thanks a lot.
Same to yours. Thank you. Bye-bye.